Good evening. My name is Steve Hernandez, and I'm the Executive Director of the Legislature's Nonpartisan Commission on Women, Children, Seniors, Equity, and Opportunity. We are here tonight to host a virtual public forum on one of the issues that is most present on so many of our minds, and that is COVID-19 and the coming vaccine. The topic of today's conversation is building trust, the COVID-19 vaccine in the African American community. People of color, particularly African Americans, have been hit hard by the coronavirus, but achieving racial equity in the vaccine rollout may be easier said than done. Tonight, we're having a candid conversation about vaccine safety amid a painful history of racial discrimination in the US medical field. We have such an illustrious panel. I just want to mention who the panelists are. We are going to give each of them an opportunity to both introduce themselves and give some opening remarks. We're joined by Shawn T. Wooden, the State Treasurer of the state of Connecticut. We're also joined by Dr. Duncan Harris, the CEO of Capital Community College, Dr. Tabitha Fortt, an MD and an LLC with a family medicine specialist or specialty, and Dr. Fred McKinney, professor of Quinnipiac University, and finally, James Michel, the Chief Executive Officer of Access Health Connecticut. We will be joined by Dr. Deidre Gifford, the Department of Public Health's Commissioner, who will join us as we are into the broadcast. Without anything further, I'd like to start this conversation. I want us all to consider tonight's conversation a conversation in the spirit of nothing for us without us. Because what's been so apparent in the last few months is that there has been at first a hand-wringing, but then a real effort to try and bring and build avenues of conversation with communities of color, especially understanding that the pandemic has disproportionately hit communities of color in ways that we should have anticipated. So without much more characterization, I want to turn first to Fred McKinney. Fred, Dr. McKinney, there is a reason that we're here today to talk about building trust between the African American community and the medical community and our state infrastructures around pandemic and around vaccine. So I'd like to introduce you and have you give us a little bit of that history.
Well, thank you, Stephen, and also welcome all of the other panelists. Glad to be here this evening. In terms of the reason, the historical relationship is what we're talking about between the African American community and the medical profession, the healthcare industry as a whole, goes back to our days first here in this country. But there's more recent history that I think has a huge impact on what we're talking about in terms of vaccine hesitancy. And that hesitancy, there's a reason for that hesitancy. And I think one of the challenges that we are facing as a country, as a state, is how do we overcome that hesitancy to improve the health of members of our community during this pandemic. And so in terms of that history, I mean, there's so many different examples that we could point to that explain that hesitancy within the African American community. And it's almost like you learn these things when you're a very young child, when you hear maybe your grandmother, your grandfather, or your uncle or your aunt talking about some particular experience or some memory or something they read in Jet magazine in 1950. And so, let's take some examples. As I mentioned, in the last century, in the 20th century, there were several examples of where the medical industry, the research industry, the hospital, the healthcare industry in general, had this very strained relationship with the African American community. So we all know about the Tuskegee experiments, where physicians and researchers wanted to understand how syphilis impacted the body. And so they conducted experiments where some Black sharecroppers in Alabama were given the placebos and some were treated. But the folks who were given placebos essentially were told that they were getting the drug. And so they suffered really full-blown syphilis for a long period of time. And this is not ancient history. While that experiment started in 1932, it didn't officially end until 1972. So many of us on this call were around in 1972, I suspect. And so this is not ancient history. You also have the case of Henrietta Lacks, whose blood was used. She was a cancer patient, and this was a case of not having full disclosure between the medical industry and an African American woman whose cells were used to develop for some really good purposes, quite frankly, to experiment and also to treat certain types of diseases. In fact, from what I understand, some of her cells are used in the development of COVID vaccines. And so this is, again, something that we still are dealing with. And another one that I would point to that, again, is ingrained in sort of the African-American mindset are the experiences of Dr. Charles Drew, who during the Second World War developed one of the main techniques for preserving blood cells and separating blood from plasma to the cells so that they could be stored. And he was, one of the most well-recognized physician researchers in the country dealing with blood and how do you preserve blood. And this was a big issue because on the battlefield, soldiers who were injured needed blood. And he interestingly had one of those fights that Black folks have had with institutions for a long time, when he was told by the Army he was supposed to separate Black blood from white blood. And Dr. Drew knew that there was no difference between white blood and Black blood. Blood is blood. I mean, there's different types of blood, but it's not based on race. And so the story goes, he resigned from that position. And his story didn't end there. His story ended tragically with an automobile crash on his way to Tuskegee, which is interesting. And he died in that automobile crash in a rural North Carolina hospital that had been essentially established to treat white patients. And so, it's not clear whether or not he was given the level, the quality of treatment that he should have gotten. Did he get the blood that he needed, that he had a personal sort of relationship with the development of that technology? And so there's a huge irony there that seems to keep popping up when it comes to the issues of the Black community and the healthcare community. And that's not it. I mean, we could talk about the experiments that were done on prisoners of color throughout the South, whose bodies were treated like lab rats. And so people had relationships with these folks who went into prison one way and came out a different way because of the treatment that they received from prison doctors and others who were experimenting on their bodies and their minds. So this is a significant sort of reason why we have this strained relationships with the medical community when it comes to things like vaccines. And I'll just add one more thing, and that is the whole technology of vaccines is somewhat counterintuitive. And if you go back to some of the earlier vaccines like smallpox or polio, the technology is you give somebody the disease or a version of the disease that has not going to kill them, not going to hurt them, but it's going to generate antibodies in their system so that they can be protected from the disease. And for that counterintuitive sort of method is something that I think some people have a difficult time wrapping their hands around. You say, you mean you're going to give me the disease that I'm trying to avoid? And so it needs to be explained, and and people need to understand it, as opposed to no, just take the shot. That's not good enough in communities who've been exploited historically.
Thank you, Dr. McKinney. You know, you strike a chord with the notion of informed choice, because informed choice is a two-way street. When making decisions about our healthcare, we have to ensure that that we express our desire to learn about what is really at the core of this medicine. What is it that we are? Why are we taking this medication? How does it work? We want to make informed choices, but there's also a responsibility on the side of not only leadership, but also the healthcare profession to communicate and to inform and to educate the public about what it is that, why it is that it's important that we seek healthcare to begin with. And of course, avail ourselves of life-saving vaccines when they are available. So thank you for that history, Dr. McKinney. We are going to come back to that because I think it always bears repeating that the distrust within the community, within our communities, not only toward the profession, but toward authority and the control of authority around information has a historical foundation that is very recent, within generations, if not within our own. So thank you for that. I want to turn next to Treasurer Wooden. Treasurer, you know, and about distrust, you know, we want to talk about the role of leadership and the role of leaders in communicating and setting an example, leading by example in not only communicating, but also really discussing the importance of informed choice. So Treasurer Wooden, you are a leader that does lead by example, and we're really happy to have you here. So welcome, sir.
Thank you, Stephen, and thanks to the Commission for inviting me to participate tonight. I'm State Treasurer of Connecticut. Obviously, I deal a lot with numbers and money, but this issue is something that I'm extremely passionate about, and really happy to be with such an impressive group of thought leaders in our state. And I think, you know, coming out of, you know, take a step back. So I am the only statewide elected official that's African American. I'm the only statewide African American elected official in New England. I'm the only African American treasurer elected in the entire country. And 2020 was a year of racial reckoning, right? And it started with a health pandemic. And that's what we're talking about right now, that exposed so much in terms of disparities in our society along race and class. And that goes on to the economy, and we look at the economic recession, that goes on to police. And so this was our gateway, this pandemic, into opening up the eyes of many more people in Connecticut and Americans towards these great disparities. And so when we get to, you know, it's been a really, really hard year on a lot of people, and especially people of color. And now I see light at the end of the tunnel. I say it's still a long tunnel, but there is some light with the vaccine. There is some light, and we are confronted, people of color, and it's not just African Americans. You know, there are experiments done with Puerto Rican women on the island in the 50s around birth control and experimentation, you know, and again, without informed consent. More recently, you know, we look at what's happening in detention centers and hysterectomies being performed without consent on women. This is very real today in terms of, you know, we have this historical context, and everyone in the African American community, you know, knows about the Tuskegee experiment, and that is fixed in our minds. But we also have the present day reality of a system that is still unequal, that a system that you walk through the door, and as we've seen recently reported with a African American female physician who has died of COVID, who she felt could not get the proper care in the system. So we have a historical context, and we have a present day reality that says, we don't trust you, government, we don't trust you, healthcare system. And so at that same moment, the brightest light that can help save our community, save others, is this vaccine. and we are confronted with colliding of mistrust. And I felt as in my capacity, in my role, that I needed to step up and to lend my voice to this effort. And it became crystal clear to me on Thanksgiving Day, which I typically host, but I had no one over to the home, but we did a family Zoom from Seattle to Houston, Georgia, North Carolina, all over the country. And we turned to the vaccine and how many people, once a vaccine is approved, would take it. I was shocked. Despite everything that I just said and everything that I know, I was shocked at how few hands went up on the screen in terms of my family. And after that, that's when I made this call to action of calling on Black and brown leaders to stand up, because we, I think you first have to understand and acknowledge the history, right? People of color are not crazy for being paranoid about the system as it relates to healthcare and health choices. But if we, based on everything that we know, and there is so much misinformation about this vaccine and vaccines generally, as Dr. McKinney, talked about, it's incumbent upon us, right? Wherever we stand, whatever we do, a treasurer, a pastor, a community activist, a physician, it's incumbent upon all of us, if we have more information, to convey that, right? So I think it starts with validating the fears and the reality of our experience in this country. Then we have to educate with all the information we have, and we're going to hear more about that tonight. But with that information, it's powerful. And then I don't even think that's good enough to simply educate. We have to, and this is why I made a call to action to Black and brown leaders to stand up and to commit to publicly, on camera, take the shot, because it's about putting your money where your mouth is, as they say. And I think that combination can be a powerful combination to save lives, because everybody wants the vaccine except communities of color who are like reticent. And that would be the tragedy on top of the tragedy of this pandemic, is if we continue to get infected at higher rates, get hospitalized at higher rates, die at higher rates once we have a vaccine, because of this well understood fear. So and I continue to call on everyone, and obviously, we have the believers on this participating tonight, but I think it's critically important in terms of saving lives. And love to, we have a doctor here and the Commissioner of Public Health who will talk more about the science and the health around this, but I'm happy to jump in there too, because I think the studies are powerful, right? When you think of people taking the flu shot with ease and with a lower efficacy rate than these vaccines, but we'll get into that. But I think that information is powerful, and I've seen it move people.
Thank you, State Treasurer. I do want you to bookmark that thought, because you're right. We are going to come back to that when we come into the open conversation part of our evening. I do want to acknowledge, as you said, that Commissioner Gifford has joined us. Welcome, Commissioner. We will be building up to your presentation. But I want to say, the relationship between what you just said, State Treasurer Wooden, and what Dr. McKinney said about that irony, that confluence of ironies, where so much of the early work on medical breakthroughs were done on the back of Black and brown people, and because of the in some ways, the intentional and peculiar ways in which Black and brown people have been kept from adequate health care, the irony that and lack of information, that it is Black and brown people who are most reticent to getting this powerful and beneficial vaccine. And that same conversation that you had around your table, we had around our table as well. And we're a second and third generation Latino family. And there are very few members of my family who want to take the vaccine for all of the reasons that you described. So I think it's powerfully important that you have called for this action, and leaders need to lead in this conversation. So thank you, State Treasurer. Dr. Duncan Harris, I want to turn next to you. You know, you have different perspectives on this issue, not just as a leader, an executive in an educational institution that serves the heart of our state here in Hartford, but also as a leader yourself in the Black community and as a person who has personal experience in this issue. So welcome, Dr. Harris.
Yeah, glad to be here, Stephen. And I'd imagine the audience can deduce that our treasurer is also an attorney. And so I'd suggest that his opening argument tonight builds a compelling case for the rest of us to build on this evening as to why it's so vital for our community to adopt, the vaccine. And so, who's Duncan Harris? I am multicultural. So my father is from Opelika, Alabama. And so you mentioned before some of the history there. And my mother is from Nevis, a small island in the Caribbean. And so, one of the things as we talk about the histories there, the long-standing traditions in culture as it relates to adoption of medicine, and I wanted to speak specifically to two concepts of influence and confidence as it relates to adoption of the vaccine. And so, in the area of confidence, as I'm looking at what would cause me to adopt the vaccine, it's when I see people who look like me in a concordant way taking the shot. And so, we're on Facebook now. I'm from Bloomfield. I'd imagine there may be some other folks. And when I saw Dr. Katrina Sanders, who I graduated from high school with, who's now a physician, on Facebook, somebody who I have confidence in, getting the shot, and a concordant relationship that had significant influence on me. Dr. Reginald Eady, who's also a friend, and his suggesting that this is something that is good for our community and something that he's doing himself, allows me to have confidence. I'm a fan of Dr. Fauci. However, when I see somebody in a very concordant way adopting the vaccine, somebody that I have long-standing history with and trust, the idea of me that building a case for support is clear. And so, I echo Treasurer Wooden's concern of how important it is for people in our community, like Dr. Fortt tonight, that we have confidence in and concordant relationships with that promote and endorse our members of our community getting the vaccine. As you alluded to, I'm a leader in the African community, African American community. I'm a member of various organizations. I've grown up here. I am the CEO of one of our state's most diverse community college. That's 36% African American, in our state capital. And I recognize the influence that I have. And you mentioned earlier that I have a unique experience. I actually contracted COVID back in March, and I was very sick from March 20th through the 29th, which was early on. As folks were contracting COVID, and I've never been that sick in my life. And one of the things that I did, was that I shared that experience via email with all of my faculty, staff, and students. And you would be amazed, and I actually saved many of the messages that were sent to me by individuals that were disbelievers, or that were believing that it was a hoax, or that somehow they had an S on their chest. And for them to know that their college CEO had the virus and was gravely ill as a result of it, really it hit home. And so what I know to be true with regard to this vaccine is the importance and significance of us ensuring large scale adoption to avoid individuals getting what I had that caused me to think about not being here for my family and community. And so there's a piece to me wielding the influence and trust that people have in me based on being a leader, father and husband and educator in our community to unabashedly uh, suggest and claim that the importance of mass adoption of the vaccine in our community. And so I implore more leaders within our so that have influence and whether that's our faith leaders, whether that is our the coaches and teachers and leaders of various community-based organizations. I think they need to be out in front, encouraging and wielding that influence for the good of our community. And so this we had the chance to talk about this hits home for me, and recognizing how much life has been lost as a result of not having access to the vaccine, so that now with on the embarking on wide adoption of it, I would hate to think that there are barriers based on misinformation or those that have influence not exercising that influence for the good of our community. And so so that's where I'm at on this, and look forward to the rest of the discussion this evening to chime in.
Thank you, Dr. Harris. You remind us that even opportunity and recovery is relational, and so much depends on the relationships that we have. And those relationships include our relationships with our healthcare professionals and with our own health outcomes. And oftentimes, some of those barriers can be daunting. The barriers of cost, the barriers of access, all the different reasons that people in our communities do not seek healthcare or are unable to seek healthcare. And then layer on top of that fear, misinformation, or lack of information, and it is really difficult, or rather, it is easy to see why there is disproportionate impact in our communities. So thank you for that. Thank you for sharing your experience as well. I want to move next to Dr. Fortt. Welcome, Dr. Fortt. You are a physician, and you come with a perspective of being what I call a physician, but I also consider you a public servant, because so much of what you do is in service to people who really need the help and intervention. So I want to welcome you to our panel.
Thank you, Stephen, and I am greatly appreciative to be a part of this panel. As you said, I am a family doctor here in Stanford, where I work. I actually have worked in private practice. I'm currently working in private practice, but also in a public health settings too. And so I just wanted to say that I agree with the fact that we do have to acknowledge the historic trauma that has been placed upon our African American and other groups within the country in the realm of the medical arena. And I do want to say, my approach to my patients, and this forum is for African Americans, so I'm gonna use that lens, but also I'm gonna say, most African Americans expect the same level of information that the general public has, and that's fair. And I think sometimes they don't hear that enough. And also, African Americans are looking for full disclosure of information. And I think, back in the dark ages, when we were in college and we looked through things in the encyclopedia and we had to look through books, whatever, that was challenging, but now we have more information on the internet. People have handheld computers that we call phones. And so there is the ability to gain more information. The general public can gain more information individually. And also, my role as a physician or as a scientist is to stay abreast of information and be able to answer those tough questions for my patients, and to give them full disclosure, at least of the information that I have. What are the risks? What are the benefits? What are the adverse reactions? Even though this vaccine is beneficial to the general public, certain people may have specific items in their medical history that need to be addressed. What are the effects on children? We haven't even done that yet. What are the effects on fertility? We haven't done that yet. We haven't had the time to look at that. And people with autoimmune diseases or cancers. So these are all things we need to talk about and address. And there is a background. Those are questions that I think sometimes are pushed in the background. And people in the African American community, when you say just take the vaccine, some of those people with those questions have even more reservations. So my role, my approach, let's manage those expectations. Let's give out the information, acknowledge the history, and acknowledge people's personal history, and also be willing to meet the people where they are. And the reality is, as simple as you think a vaccine is, let's back up a little bit. We, at least here in the Stanford community, we had trouble getting African Americans to even take the test. So, such that I actually partnered with the city of Stanford to start and conduct and help partner with the churches, the African American churches, to do the test. So before we can even get to a vaccine, even though the politicians and the medical community were speaking of the vaccines, we had to even get our people tested. And so, yes, there is a deep-rooted sense of questioning and contemplation, but we have to put that all into perspective. And so, yes, we value vaccines. I wouldn't be here, and a lot of us wouldn't be here in the relative good health that we have right now without vaccines. But we just have to not put it under the rug that people have questions and people have hesitation. Meet those hesitations head on. And one of the most powerful things that I think, as I would just say me as a physician, one of the most powerful things I can say to a patient is, I don't know, but I'll get you that information. So I acknowledge them. I acknowledge my limitations, and especially with the COVID-19 and the vaccine, this is something that's very new. We don't have all the answers. In this case, we know we don't, because it's so new. And so I have patients that I have referred for the vaccine. They call and I give my opinion. There are some patients with their things in their medical history that I'm not sure what's going on. But this is where we're going in the future. The future of the health of our country is that we need a way to, one, and I'm a doctor, so I'm gonna say, we still have to focus on prevention while we're rolling out the vaccine. And so with all of the anticipations and the expectations and the planning, for whatever reason, we haven't been able to vaccinate as many people as possible. And there's no finger pointing, it just is. And so while we're doing that, we still have to focus on prevention. And we can't forget the fact that we still need to wear our masks. We still need to social distance. And I don't have any background scientific data to prove this, but in the African American community, we know that there's increased levels of diabetes, increased levels of high blood pressure, increased levels of obesity. And all three of those carry with them the increased risk of just having a low level of inflammation. It's an inflammatory state. We know that this virus provokes inflammation. That's really what kills, or what really causes a lot of what we call morbidity, gets you really, really sick. While we're waiting for our turn.
You could just unmute.
Sorry.
There you go.
So while whether we're on the front line or, whether we're a healthy young millennial waiting our turn, just stay focused on prevention. The rollout is gonna happen. And I just want to encourage everyone to, stay empowered with information and advocate for yourself, for your personal health and the health of your loved ones.
Thank you, Dr. Fortt. And we are going to come back to those issues. For the benefit of our viewers, I do want to note that we are conducting a virtual forum called Building Trust, the COVID-19 Vaccine in the African American Community. Dr. Fortt, so much about what you're describing is about equity and equitable access to prevention, equitable access to information, equitable access to healthcare, to nutrition, to all of the things that we understand are inequities, and the outcomes that come from that are so critically important. So I want to thank you for highlighting the need for equitable work and equitable action in the way that we address, inform, and engage our communities, not only in crisis, but before crisis, so that when we get here, we have those avenues, those open avenues of conversation ready in our response. So we'll come back to you, Dr. Fortt, but thank you for that. I want to move next to James Michel. James, so much of this really does have to do with access, and whether it's affordability, whether it's options, whether it's really strategic thinking on how it is that we can bring costs down. To my mind, Access Health Connecticut in the state of Connecticut has been and is poised to continue to be one of the leading drivers of these conversations around access to healthcare. So I'd like to turn next to you, Chief Executive Officer of Access Health Connecticut, James Michel. Welcome, sir.
Thank you, Steve. Dr. Gifford, welcome. Dr. Gifford is one of my bosses as well. She's a member of my board of directors. It's nice to see you. Good afternoon. I'm James Michel. As Steve indicated, I'm the CEO of Access Health Connecticut. Thank you for having me here today to be part of this important conversation. For those of you who are not aware, or who are not aware of who we are as an organization, let me give you a quick update about who we are. We are the official health insurance exchange marketplace for Connecticut. In other words, we are responsible for implementing and administering the Affordable Care Act in Connecticut. In some areas, it's known as Obamacare. This is where you can enroll in quality and affordable healthcare coverage, and the only place where you could qualify for financial help, low cost, or free health insurance coverage provided through Husky. They are one of the areas that Dr. Gifford is responsible for as Commissioner of DSS. I'd like to share with you all the critical role that Access Health has played in helping Connecticut residents get through the COVID-19 public health crisis. There have been successes and challenges that Access Health Connecticut addressed head-on last year, a year unlike any other, with the ongoing global pandemic affecting our families, communities, and businesses alike, and with unprecedented and steady unemployment numbers and furloughs still affecting Connecticut residents and businesses. We continue to be there to support those in need. At the onset of the pandemic, together with the help of the governor, with Governor Lamont, the insurance commissioner, and the commissioner of DSS, Dr. Gifford, and others in Connecticut, we increased access to quality, affordable healthcare with a 4-week special enrollment period for the uninsured in Connecticut from March through April of last year. Most of them we enrolled over 30,000 people in that 4-week period, and most of them qualify for Medicaid. So they had access to the help that we need, and hope that we're giving them to start addressing some of those conditions that Dr. Fortt mentioned when she was speaking a few minutes ago. Many of them lost their health insurance due to the rapid increase in unemployment in the early spring of 2020. So to all of those who are helping us through this incredible moment in our time, I extend my deepest appreciation. Despite the suffering, I have seen public and business communities come together like never before. It will take a similar intense collaborative effort of business and public communities to have a successful COVID-19 vaccination effort. I'd like to speak to the moral crisis our country is facing related to systemic racism. Core to our mission at Access Health, this is in our mission, is the reduction of health disparities in Connecticut. And the hard work we continue to pursue to address these inequities, especially in communities of color, is critical. We know that health disparities stem from many sources, and the social determinants of health are well rooted. To address health disparities in Connecticut, Access Health Connecticut is developing a strategic framework to identify ways in which our organization can help address its key drivers. We are finishing an in-depth study of health disparities in the state of Connecticut. I will be presenting to our board of directors the findings, recommendations, and next steps from that study to the Access Health Connecticut Board of Directors at its February board meeting. The preliminary report identifies top drivers of health disparities in Connecticut. These drivers are health disparities that may have an impact on Connecticut's ability to distribute COVID-19 vaccines in certain communities. Most impactful, the report also identifies areas of focus where Access Health can be most impactful in helping to address health disparities in Connecticut. These new efforts to address health disparities will fulfill part of our core mission. We're excited to make a significant impact in Connecticut and look forward to creating attainable, positive changes that will affect future generations to come. Before I wrap up, let me just quickly talk about how Access Health can be helpful in this COVID-19 vaccine distribution. But now, over the last 8 years, Access Health, we have over 1 million customers in our database. These are folks that are in very tough communities to reach. They run together, and not just Black, Latino, low-income, white folks. Everybody is in our database. And again, these are all Medicaid recipients as well as health insurance purchases through Access Health. And we have developed a very unique skill set, knowledge on how to get in touch with these communities. We have built a certain trust because we spent over the last 8 years, we invested a lot of resources establishing our brand and also getting very close to a lot of community-based organizations where a lot of these communities go to for guidance and help. So we think that we are well positioned to be a trusted advisor and reach into these hard-to-reach communities. And I have to share with you, some of these communities are very unique. It's not just about trust, but they have very unique cultural norms in certain communities that we have to recognize that may get in the way of people, of the members of those communities to accept the vaccine as something worthy to them. And some of those communities are Russian, Polish, Jamaican, Puerto Ricans, Central America. There are certain parts of Connecticut where the Latino population from Central America is booming. And again, we have developed very unique outreach efforts to get in touch with those communities. And we've built a trust, and mainly through churches, through community-based organizations, to get people access to health insurance so they could start maintaining their health. So I look forward to being part of that conversation so that we can leverage our database, our resources, also our staff who have developed this 8 years of expertise on how to get in touch with these communities and get them to take action on their own behalf in hope of saving their lives and their families' lives. So again, thank you very much for the opportunity to speak with all of you today. It's been my pleasure to be part of this conversation. I look forward to more discussions. Thank you.
Thank you, James. And thank you so much for bringing up what can sometimes be even the cultural complexities of where it is that we go for our health care, who it is that we communicate with about our health needs or concerns. Sometimes those conversations don't even make it to the doctor. They can happen within a family. They can happen in a structure of elders or people with more experience in the community. So it's important that we understand the communities that we are serving and communicating and interacting with so that we can find the right avenues to get the most information so that they can make the choice that's right for them.
So Steve, you might let me share a quick story with you.
Please.
It'll be very quick. When I worked at Aetna, Aetna has a big national account with one of the national hotel chains. They have there are several big resorts in southern Florida. The bulk of their employees are recent immigrants from Haiti, and I'm from Haiti. And Aetna, they had a task force with Dr. Wayne, who was leading an effort looking at health disparities in Connecticut for Aetna. They reached out, the hotel reached out to Aetna asking them, we have this huge Haitian population that are working for us, but they're not using the healthcare that we are providing to them through Aetna. Can you help us out? So they reached out to me. It just so happened that I'm also on the board of trustees for a clinic that does work in Haiti. So our executive director was coming up from Haiti, and we met with Aetna. And this is something Aetna was not aware of. Not even the hotel was aware of this. Like most communities, recent immigrants, they all settle in a community that they all know. They bring all their norms with them. So when somebody in southern Florida from Haiti gets sick, they go to the local doctor. And this is not a medical doctor. This is the norms in Haiti. They would go to somebody who's known as the doctor to go to whatever issues you have. And they have all types of stuff they do to get you back to health. 90% of the time it works. But 10% of the time it doesn't work. People get really sick. Then they go to the hospital. Then the companies are on the hook for some big major medical bills. So they were trying to get them to find a way. How do we get this population to take steps for preventive care before it gets really bad? So we have to explain to them that you have to go into a community and find out who those doctors are who are not really medical doctors, but they're the people that can go to first before anything. They go to that home doctor from Haiti, probably somebody they knew in Haiti. And that's where they go get all the medical help first. And so we convinced Aetna that find out who those people are, connect with them, and partner with them, and have the medical doctors in these communities connect with them so that they could have a relationship to do referrals back and forth. But again, this is something that most organizations, unless they are in the community, they would not know that about that community, about how they get help. So again, this is a very unique nuances to every community across the state of Connecticut, every town, especially the big cities, Hartford, New Haven, Bridgeport. Now Danbury has developed a very densely populated Central American community. And they have brought on all of their home norms their cultural norms with them. So we have to know how people communicate and meet them where they are to get them the help that they need.
Thank you, James. You know, to paraphrase a friend in public service, it is the community that is closest to the solution. And it's for some of the reasons that you've described. So I really appreciate you sharing that story. It's a story you've shared with me before, and it really does resonate even cross-culturally. And it could be either cultural differences or familiar or inter-family tradition that can lead to some of what you're describing. So I really appreciate that. That means the professions and people serving organizations need to be more creative, and we need to be more inclusive in the way that we work on public health access. So thank you for that, James. Last but not least, before we open our open dialogue, I want to welcome Commissioner Deidre Gifford. Deidre Gifford. Commissioner Gifford, you and I, as James said, serve together on the board for Access Health Connecticut, and you are also the Commissioner for the Department of Public Health and the Department of Social Service. Your work in the last few months, I can't imagine the work that you have been helping orchestrate in the state of Connecticut in making sure not only that we have access to the vaccine as it is developed, but that it is deployed in a way that is responsible, equitable, and thorough. So I welcome you, and I'm excited to hear your presentation.
Thank you very much, Stephen. And thank you so much for inviting me and the Department of Public Health to be part of this really important and significant conversation. Thanks to the panelists that I just had the privilege of listening to. Thanks for your perspectives and input. It's been really helpful to me to listen and hear. The issues of equity and disparity and historic discrimination that you've been talking about, unfortunately, have borne themselves out in the numbers that we've seen during the pandemic, not only across the United States, but here in Connecticut as well. And as we look at data, not only on absolute number of cases, but as we look at deaths per case, and as we look at the age distribution of deaths and cases, we do see disproportionate impacts in communities of color. So we do have a particular obligation as we think about the vaccine to understand how we can make sure that whatever circumstances have led to those disproportionate impacts of the disease itself are addressed to the extent that we can in the way that we both allocate the vaccine and to your point, Stephen, which I think is a really significant one, how we implement the vaccine rollout and how we make it available to the community. You know, these two vaccines that we have before us right now, as I think all of you have noted, have been well studied through a rigorous process, and they have been determined by the FDA and the CDC to be both safe and effective. When we knew that those processes would happen, as they typically do in the United States, Governor Lamont also wanted to have another layer of review at the state level. And it was particularly aimed at trying to address some of the historic mistrust that you all have talked about. So, so he appointed Dr. Edie, who you mentioned, Dr. Harris, Dr. Edie and myself to co-chair his vaccine advisory group. And there are three committees within that group. There's a communications committee, an allocation committee, and a scientific advisory group. And in each one of those groups, we worked very hard, and I hope we were successful in having broad representation from the community on each one of those committees. And our job at the health department has been to listen with an open mind and an open heart to the feedback that we've received from those committees, because we knew about these issues that are longstanding and the mistrust that was likely to be part of the vaccine rollout for COVID. So our scientific committee looked at the process that the FDA and the CDC went through And they added another layer of recommendation to the governor and said, yes, we've looked at this process. It was rigorous. Those studies were well designed. The outcomes were fully described. Importantly, there was representation, adequate representation of minority communities in both the Moderna and Pfizer trials. And the efficacy, the effectiveness of the vaccine didn't differ based on race or ethnicity. So that was a really important finding that the scientific committee affirmed to Governor Lamont before we launched the vaccine program. The work that we've been doing over the past few weeks has been around allocation. And this has been, I would say, some of the most challenging of the work, because we're talking about some of the very issues that you all have brought to the fore tonight. And is there a way in the allocation of this vaccine, because we have more demand right now than we have supply of vaccine? Can't vaccinate everybody next week in Connecticut as much as we'd like to. We're going to have an allocation strategy. We want to be sure that that strategy recognizes some of the disproportionate impact in communities of color in Connecticut. So the committee has been grappling with that issue and trying to balance getting the appropriate populations in those groups, and making sure that we use the lens not only of public health outcomes, but also the lens of equity as we make the allocation recommendations to the governor. So the reason I was late to tonight's conversation was I was finishing up the press conference with the governor, where he announced the first set of recommendations from that committee, but they're still doing their work. They're going to meet again next week and make some further recommendations about additional populations that they may want to see prioritized in order to further address some of the issues of health disparities that we've seen in this pandemic. So that work is ongoing in terms of the vaccine rollout, and we want to continue to listen. All of those committees, once they do this work, they're going to continue to meet and continue to advise the governor and myself and the other state departments on getting the implementation right. We want to make sure that disproportionately impacted communities have easy access to this vaccine. And that means understanding what the barriers might be, whether it's transportation, whether it's language barriers, whether it's historic mistrust of certain providers or provider groups, making sure that a trusted provider is available in the community, making sure hours for vaccines are available where people who work different types of shifts have access to the vaccine, and it's not just a 9 to 4 Monday through Friday availability. All of those issues we are committed at the Department of Public Health to working with our partners to address. We have done that. Dr. Fortt, you mentioned testing and some of the challenges we faced in some communities in testing. We've worked really hard in Connecticut to make testing widely available to all communities. And we have a map where we look at poverty and population density and race and ethnicity. And we want to make sure we have testing available that matches all of those things. Places where those things are poverty, population density, minority populations are concentrated, and that our testing is matching up to those communities. We're doing the same thing with vaccine. So the CDC has put out something they call the Social Vulnerability Index, which scores certain geographic areas based on density of housing, income, other risk factors for poor outcomes for COVID. And we're going to map our vaccine availability to those high scoring areas for social vulnerability in Connecticut and make sure that there's access in places where it's needed. And we'll be looking to not only community leaders like yourself, but to the governor's advisory group and their subcommittees to working with us to monitor that, give us feedback as the vaccine process rolls out so that we make sure that the access that we're so committed to is actually materializing on the ground, because the best laid plans sometimes don't translate into actual access on the ground. We've also been working with our contact tracing team. As you know, we have several hundred people who work on the phones all day long. They call people who get a positive test. They let them know that they need to isolate. They ask them about who their contacts are. And then they often end up answering questions about COVID disease for those individuals. But we know that trust in sharing some of that information is critical. So we've been working with the CDC, and we've hired what we call community outreach specialists from disproportionately impacted communities. They live there, they're of those communities, and they're working with us on the contact tracing team to do outreach, particularly in those hardest hit communities, and make sure that we are providing culturally appropriate and culturally sensitive contact tracing feedback. We've also hired a number of what we call community resource counselors, so that if we hear in one of those contact tracing calls that an individual is having trouble acquiring food, acquiring medicine, acquiring healthcare, that they have behavioral health needs, if they're unable to isolate or quarantine because they live in multi-generational or crowded housing, we have these community resource counselors that we can refer them to. They're funded by the state. They work with locally based community organizations to provide, do our best to provide the resources to individuals who need them. So these are among the efforts that we've been making to try to address historic inequality and disproportionate impact. There's always more that we can do. But when it comes to vaccine, we're taking the lessons that we've learned from testing and contact tracing, and we're applying those to the vaccine implementation and allocation process. And we're committed to continuing to iterate on that to make sure that everybody who wants to get a vaccine has access to vaccine, and particularly in those communities where it's most needed.
Thank you so much, Commissioner Gifford. You remind me of early on in the pandemic when our response infrastructure of the state first activated, and it activated very, very quickly. Some of the first calls that I saw and heard in those tables of response was, where is the diversity? Where are the communities represented? Where are they? And those calls were coming from inside the table. So I really want to thank you and others in the administration who really very early on said, if this recovery is going to be meaningful, it has to be diverse. And this is a relationship, and systematizing access, systematizing trust is part of the sacred duty of the work that we do. So I thank you very much for that. I want to open up the conversation. I'll start with you, Commissioner Gifford, because there was a question from one of our viewers, and I encourage our viewers to ask questions as we move now through the open discussion. But will there be a cost to the vaccine, Commissioner Gifford?
No. The federal government has committed to no out-of-pocket costs for the vaccine. The providers are able to bill insurance for the cost of administering the vaccine, but there should be no out-of-pocket cost to an individual. We want to know if people are getting charged for the vaccine. That's not something that we want to see. So we want to make sure that the state is hearing about it if there are charges for the vaccine. And I want to say, even for individuals who don't have health insurance, thanks to the great work of James and his organization, thanks to Husky, thanks to Obamacare, in Connecticut, we have a very low rate of uninsurance, one of the lowest in the country, but we still do have individuals who are undocumented and individuals who don't have coverage. As James is much more expert than I am. But even individuals without insurance, there's a fund set up at the federal government to pay for your vaccine. So there should be no financial barriers.
Thank you, Commissioner, and thank you for noting the plight of the undocumented. We will be having a separate conversation as a commission on the unique trajectory and the unique experiences of the undocumented, COVID and beyond. And that is one of the issues that we'll be looking at. So thank you so much for that. James, I know that you had a question for the commissioner as well.
Sure. Thank you, Steve. Commissioner, as I travel around the state, I get a lot of questions. One of them, in the middle of our health disparity study that we're going through right now, one of the contributors to health disparity is that the follow-up by somebody from the Black community, Latino community. And, you go see a doctor, you have to go back and do a follow-up or come back, get test results. A lot of times the follow-up does not materialize for a lot of reasons, work, transportation. So given that these vaccines are taken in 2 shots, if you get just 1 shot and you're not able to come back for the second shot for whatever reason, what's the impact? What's the impact of just getting the first and not the second? The second question that I get a lot is, do we know what the long-term impact is to the vaccine? Just personally, I'm going to take the vaccine. Me and my family, we would all get the vaccine. But friends of mine, when I'm talking with, they say, we don't know about this 5 years from now. What's going to happen to me? Given this vaccine was developed in 9 months or 8 months or less than a year, do we know what the long-term impact is? Again, I want to stress that I'm going to take the vaccine. Me and my whole family, and we're going to encourage our friends to do it as well. But the ones that are apprehensive about it, those are the questions they ask about the long-term impact.
Thanks, James. I'll take a stab at both of those and I'll do my best. On the first question, which is a little bit easier, the studies have been with 2 doses, 3 weeks apart for the Pfizer vaccine and 4 weeks apart for the Moderna vaccine. So we know that the best immunity, the 95% effectiveness, is conferred if you get both doses. So we really want to encourage everybody, if they can, to get both doses. The good news about some of the challenges that you stated is that it doesn't have to be at exactly 3 or 4 weeks, right? If you're late for your second dose, you go in anyways. And there's no time when it's too late to get your second dose. So even if it's a month later than your scheduled appointment or 2 months later, you can still go in and get that second booster dose and get fully immunized. So that's the good news, that it doesn't have to be on an exact day. The timing is not that sensitive. It's just plan to get the second dose as soon as you can. And if you get it at the 3 or 4 weeks, you'll be fully immunized sooner. But if you can't, then get it when you can. On the issue of long-term side effects, you're correct, and that this vaccine is new to the market. We have to acknowledge that, to Dr. Fortt's point, right? We have to acknowledge that this is a new product. What we do know, though, is there were 2 months of follow-up in both of the studies. The vast majority of side effects occur within a week of the vaccine, and among those side effects, almost the majority occur within just a few days. So, and that's true of all vaccines. Side effects typically happen in the period immediately following the administration of the vaccine. You might recall there was a little controversy back over the summer when the federal administration was pushing the FDA to approve with only 30 days follow-up, and the FDA pushed back and said, no, we typically get 60 days follow-up because we want to make sure that we catch all of the side effects that might happen in any 60-day window. So, so that is a typical approval period. And we have seen some side effects with allergic reactions. Pain in the arm is common after the second dose in particular, just like it is with flu vaccine. Fever, aches, fatigue, those things are fairly common with vaccine. We also saw some of those side effects in the placebo arm of the studies. So we know that they're not always directly related to the vaccine itself. And we also know that vaccines in general are very, very safe products. The risk versus benefit profile of vaccines, Dr. Fortt mentioned that many of us probably wouldn't be here today if it weren't for vaccines. It's definitely true. I'm old enough to remember, parents of my friends that had polio, for example, and the world-changing nature of the polio vaccine and how that liberated so many people from fear. So we know that vaccines in general are very, very safe. These appear to be no exception. We have to acknowledge that we're gathering the long-term side effects as we speak, but we don't anticipate seeing anything untoward from these vaccines. I hope that answered your question, James.
Well, absolutely. I hope the public who is participating in this discussion hear your answer, because it's important that we clarify that if there any impact at all, it happens in the first 2 months, and that was part of the study. Because a lot of folks are concerned about that long-term impact. So I appreciate the clarification, and I will share that with my friends and colleagues when they ask me that question. I'll have a more informed answer for them. Thank you.
Stephen, if I could say.
Go right ahead. Thank you
Yeah.
both. Thank you, Commissioner. Go right ahead, State Treasurer.
No, it was Fred McKinney. So
Oh, Fred, go right ahead. I'm sorry.
that would be a promotion. But
I trade with you any day, Fred.
but I was going to say that we started getting vaccines in arms around December 14th, 15th in this country. It is now January the 7th, almost a month. We've over that time frame, we've vaccinated over 4.5 million Americans. And while, with the 30 days that we're still within that 30 days, we've heard very few cases of problems. You had some early issues in Alaska where someone had an allergic reaction and they knew that they had an allergy to or were very sensitive. And the profession, the medical profession understands, when they're dealing with their own patients and with the questions that they're asking people before they get the vaccine, and not everybody knows their condition, but if they do know that they have an allergy, that the type of allergy, those kinds of things, they need to share that with whoever is administering that vaccine at that time when their time is up. Because what's going to happen is if they do have an allergy of some sort, they're probably going to ask them to stay here for a while so we can observe you before they send you on your way. But I think the real good news with this vaccine is, and we haven't heard of any major adverse effects with over 4.5 million vaccines in arms, and so that's really good news. It's not to say we won't have some serious adverse effects, but the numbers right now are pretty impressive.
Thank you, Dr. McKinney. I'm going to come back to you on the bigger questions of trust, and I'll come soon to Dr. Fortt on some of the questions and comments that we're seeing in the feed. But State Treasurer Wooden, I know that you had raised your hand.
Yeah, so I want to, this has come up a few times around kind of the long-term impact. And it's a question I ask. I think the most honest answer is that we don't know what 2 years looks like. We don't know what 3 years looks like, right? We don't have the science to support that, right? And so when we talk about informed consent and being transparent, we have to acknowledge that. What I do know, and what the science supports, is that the long-term impacts for many people contracting COVID are pretty harmful. And I had to do the whole cost benefit analysis and think about that fact that we don't have an answer to 2-3 years from now. We are getting some answers to what it looks like. And I remember the day it hit me last year that said, yeah, I'm afraid of dying from COVID-19, but I'm also afraid of living after having it, based on some of the outcomes. Right. And so thinking about that and taking what the commissioner has said about what we know about vaccines safetiness generally, I think we need to start debunking some of the myths and misinformation about this. And I think this would be a perfect time to do so. And I'm going to raise them, and perhaps Dr. Fortt or the commissioner or anyone may be in a better position to answer it. And if I say something incorrect, let's put it out here now. One is that this vaccine was developed just like every other vaccine in terms of safety protocols, standards, phase 1, 2, trials, nothing. It feels accelerated because it was, but it's more of a function of putting resources, putting additional financial and labor resources into it. So if you think about someone spends 8 hours a day working on a vaccine, and all of a sudden you're going to spend 16, you're going to get to vaccine development faster, but it doesn't mean you cut any corners. So I think, is that correct? I just want to.
That is absolutely correct. It's an excellent point.
Okay. You raised this point, but I want to emphasize it because I've gotten a lot of these questions, particularly, making this call to action for folks, that the studies, but I think it bears repeating, they said, well, were Black people in the studies? And the answer is absolutely yes. And there is data and adequate sample size to say what's the impact in those studies on people of color. Okay, check.
Yes, you're correct. And that has been, for all the reasons that you all were discussing at the beginning of this conversation, that's been a challenge historically, as you know, having adequate minority representation in clinical trials. So, but knowing the impact of COVID on communities of color, Pfizer and Moderna were under pressure to make sure that minority communities were adequately represented. And I commend them for the kind of recruitment efforts that we made. Some of them were here right in Connecticut, where we had a trial site at Yale New Haven Hospital. And they were able to successfully recruit adequate numbers of people of color in proportion to their representation in the general population. So yes, there was adequate representation.
Okay. And with respect to kind of the development and the approval process, there are African-American physician scientists who are involved in all levels, right? So Pfizer, I believe one of the lead physician scientists is an African-American woman based out of Yale with the Pfizer development. With the FDA approval process, African-American physician scientists have been involved in that process as well, but I believe.
I know that there is diverse representation on the CDC Advisory Committee. I know that our principal investigator, because I was on, had the privilege of being on another panel with him, our principal investigator on the Pfizer trial at Yale New Haven Hospital is an individual of African descent. I can't tell you specifically on the FDA. I just don't know. I do know that as a general rule, they work very hard to make sure there's representation on those committees. Maybe somebody, a fellow panelist, can answer that question, Treasurer Wooden, for you.
Yeah, and I can't recall the name, but in terms of that advisory committee process. So anyway, those are just some of the things, because I've heard so much. And I think as part of this educational effort, we need to get it out there and have people understand, right? Because in many respects, this is no different, or maybe in all respects, it's no different from any other newly approved drug or treatment. But the skepticism level is way off the charts in a way that's different from another drug that the FDA gives a green light to. And that's not warranted based on the process and everything that's been done in terms of that.
Thank you, State Treasurer. The debunking and the of myths, but also the solidifying of information is so critically important. And I'm so glad you did that, because it really does respond to even some of the questions that we're getting in the feed. Dr. Fortt, one of the questions more specifically really is emblematic of the times. You know, you see disproportionate treatment when it comes in health, disproportionate treatment in education, in law enforcement. You see it on the news, you see it in our everyday lives. So people are asking, how do I know if I go to a medical practitioner and I'm standing in line waiting for the vaccine, that they're not going to give me something else, a placebo, or that it's not going to be switched out? These are questions that people have. And what do you say to those who are skeptical that they, by virtue of being Black or brown, are not going to get the same level of care or intervention as they should?
You know, as I stated before, you know, I acknowledge their feelings of distrust, and all I can do is just encourage them that, you know, many of us as clinicians, we have a level of integrity that didn't start yesterday. It started years ago. And so, you know, we have to make, we're in a position where sometimes the decisions and that we make and the answers that we give, they're not always what you want to hear, but we are bound under oath and under law to be truthful. And so to the best of our ability, we will give out a vaccine that is not expired, that is stored properly, that is not altered in any way. It serves us no purpose to do that. And so I can only tell them, you know, encourage the average person to realize that that is our, not just historic background, but that's what we live by every day. The level of integrity that the medical community instills and requires of us.
Thank you so much, Dr. Fortt. You know, it's really a question of share what you've learned and share your concerns. Talk to your medical professional, talk to each other, talk to your community leaders. Really dig deeper for the answers to these questions if you have a question, and certainly if you have a concern. You mentioned, Commissioner Gifford, in the no cost of, or the fact that there is no cost for the vaccine. If someone is charging you for the vaccine, raise that concern, because it is important that we are all partners in holding every level of the response accountable, but also sharing that information that you learn with your families, your friends, and your colleagues. So thank you for that. You know, Dr. Harris, I'm recalling a conversation you and I had about the importance of really ensuring that there are people of color in all the professions at every level, and leading in an institution that is in a lot of ways a feeder to so many of these people-serving professions. I wonder what your initiative is to ensure that there are more people of color in these valuable professions that are people-facing and trust-building.
Yeah, it's interesting you mentioned that, and I'll provide a response to that, and I also have a question for the commissioner following that. But yeah, Capital Community College, as I mentioned, one of the most diverse community colleges in New England. As a matter of, and certainly in Connecticut, we're 36% Black, we're 31% Hispanic. We're a Hispanic serving institution, and we have the largest nursing program in the state. And so certainly this idea of the individuals coming through that program that are employed in our area hospitals that come from the communities within which we serve. You know, we are Hartford's community college, and you look at the diversity of the city. And so we have an obligation to prepare, you know, our diverse healthcare workers, you know, for the state and for the hospitals in the region. So there were a number of things that came up tonight that caused me to think about the importance of us having more Dr. Forts, right? And individuals. So this idea of trust and concordant care, and you know, I think that, and I'm in higher education, and one of the things that and some of my research work was in a similar fashion to healthcare, the idea of concordant mentoring relationships, and this idea that I'm more likely to disclose things that may be ailments that I have with somebody who looks like me and who has a similar background, similar fashion to me having a counselor or advisor or mentor that has a similar cultural and ethnic background as me. And so certainly I you know, this idea of the need for us to have more Black doctors and healthcare professionals, and as it relates to the equity issue, and quality healthcare and eliminating disparities in healthcare is relevant for this discussion. The question I had for Commissioner Gifford, and this comes from, and I'd imagine many of the folks listening tonight, I've already begun to start seeing memes and kind of anti-vaccine things on social media, right? And we're very aware of the detrimental impact of irresponsible social media on all communities and communities of color in particular. And so I wanted to ask the commissioner, notice that you mentioned something about the communication plan as one of the key areas. And I'm wondering, the other day I saw a very positive promotional piece on the vaccine by an individual from the Caribbean, and I shared it, and there were probably about 200 people that liked it, put their hearts on there, and shared it themselves. And so I'm wondering if you could share a little bit of information about the media campaign that's coming, and how we could be useful in helping to get that word out.
Thank you for that question, that offer. We did so. We have learned quickly as we've rolled out the vaccine in our nursing facilities that the uptake among workers in the nursing facilities, many, if not most of whom are women of color, has been very low. 40 to 50% of the workers in our nursing facilities so far have taken the vaccine. And it's not that much more among other healthcare workers. I might have mentioned this in my earlier comment. So we got together with a couple of nursing homes and with the union that it's a part of a lot of our nursing facilities. And we put together some testimonials. This might have been what you saw, Dr. Harris. Some testimonials from individuals who had received the vaccine and why they took it, and what it meant to them, what it meant to their families, their communities, to the residents of the nursing facilities they work in. And we've put that together into a PSA. We have a short and a long version, and we're happy to share that, Stephen. I'll make sure that you get a copy. That is the type of work that we are intending to continue to do. Working with our communications committee that the governor put together, which is a very broadly diverse group. We have representatives of the clergy, we have representatives of labor, the business community, advocacy organizations, and they are poised and ready to help us get the word out. I will say that we've been kind of busy, and we're still ramping up on the communication, but we understand how critical and important it is. So welcome your offer, and at least on this one video, we'll make sure to share that with Stephen and get that around. And as things roll out, continue to share as well.
Thank you. Thank you for that, Commissioner. One of the things that we will do with this presentation is that we will be sharing several of the links and other information that you have been referencing, you and others have been referencing in this conversation. So I invite you to send those links and further information to us so that we can share them on your behalf. I do want to note that one of our viewers, Dr. Ravita Fuller, notes that she is an African-American and a virology scientist who serves on the FDA's Vaccines and Related Biological Products Advisory. So she wanted the public to know, who may be watching, that she was one of the reviewers. She raised her own concerns, and that's what it's so critically important that scientists who are involved be as diverse and as informed and have their finger on the pulse of the communities that they are serving. So thank you, Dr. Fuller, for your service as well. I know that you're watching. I wanted to. There's a question that's this is a little bit more wonky, and it's the question of the mRNA. Is this new? And Dr. McKinney, you noted in the comments something that I'd love for you to mention, just for the benefit of our viewers. While a lot of this work has been expedited through resource, we focus more on it in a concentrated way, as you noted, State Treasurer, and that's why it came so quickly. A lot of this work is not new, and it's been going on for a lot of years. Can you talk a little bit about that, Dr. McKinney?
I can talk a little bit about it because I will share with you what I know. I happen to have a daughter-in-law who's also an immunologist, and she shared with me a little bit of the history of the mRNA drug, and it is wonky. I mean, it's a technology that's being used with this vaccine. And although this, we just started working on this vaccine this year because the COVID-19 is something that is new. But the technology of the vaccine is not new. And so what has been developed for over 30 years of work and research and application is what's been brought to bear on the development of this specific vaccine. And I think that's important to note because it allays the fear that consumers legitimately might have, and says, well, you just started working on this last week. No, this is a technology that's been around for a while, and the medical research community is familiar with it. And so I think that should help people understand that shortcuts were not taken. This was a technology that's been around for a while.
Thank you, Dr. McKinney. State Treasurer, as we think about all of the various impacts of this vaccine, we can't ignore the economic impact that is also disproportionately felt on communities of color. And that economic recovery that we are all committed to, and that we have ensured, or at least tried to ensure, is as rich and diverse, so that we are better off after this than we were before, is so critical to communities of color, Black and Brown communities. And recovery depends on vaccination, and it depends on us being able to move past this pandemic. So can you speak a little bit about to that intersectionality and the work we're trying to do?
Yeah, and I've talked a lot, actually, generally about the relationship between the pandemic causing the recession and the harm, and our way back to a stronger economy is to tackle the pandemic and to get that under control first. And so in the context of this discussion, both the pandemic has had a disproportionate impact on the African-American community. Also, when we look at economic conditions, it's very, very similar, disproportionate impact. The type of work that a lot of Black and Brown communities, are essential workers, frontline workers, and if we don't tackle within our community kind of the health of our community, the vaccinations, and then as the recovery takes place, and there will be a recovery, we will lag behind again, right? There's the old saying, when America generally gets a cold, the Black community gets the flu. And this is kind of very similar. And so if we lag behind, and if we don't do the work to get vaccinated and to protect ourselves, and Dr. Fortt, this should be reset. Yes, mask, social distance. That is the best thing today that you can do to protect yourself and for some time in the foreseeable future. But all of that's going to impact the economic health of our communities disproportionately, and we will take a longer time to dig out if we do not take this seriously in terms of our health care of our community right now.
Thank you, State Treasurer. Dr. Fortt, I'm sorry, you're a physician. I'm going to come right back to you because one of the questions is relevant to you, which is a very simple question of whether there is live COVID-19 in the vaccine. Should I be worried about that?
So all the information is out there, right? There are no live particles in the vaccine. And to Dr. McKinney's point, and speaking about the messenger RNA, or you hear mRNA, the technology has been there for years. And 30 years ago, was I in medical school? Yeah, I just started medical school maybe 28 years ago or so. But the technology was being used and applied to chemotherapy, and how do we deliver one messenger RNA to potentially kill another virus or what have you. So it is not new, as was stated. There are no live particles, but there is a segment of the genetic material from the virus that in the vaccine our cells then use to make antibodies. And so the fact that the technology is 30 years old, the fact that we already know how to make antibodies, or we already have vaccines that make antibodies, putting the two together did make the process quicker. And so to that point, it is faster than any of us have been used to, but the necessity for that, the quickness of finding a solution was apparent.
Thank you, Doctor. Is there anything you'd like to add, Commissioner?
No, that was very well said. I think one way I heard the mRNA technology described is that it teaches our body to make antibody. I kind of like that way of describing it. I don't know if that resonates with everybody, but it is really an exposure to a tiny piece of what stimulates our bodies to make the antibody, but it does not involve introducing the virus at all into our cells. And the genetic material that Dr. Fortt mentioned never gets deep inside our own cells either. It gets far enough to teach our body to make the antibody, but it doesn't get integrated into our own genetic material, which I think people also have had some concerns about when they hear it's genetic material. I've also heard, and I want to just say this out loud, I have heard rumors about microchips being in the vaccine, and I don't know if those are rumors that others have heard. There's no evidence whatsoever of that. It would be very, very difficult, if not impossible, to actually put that into the vaccine. So this is not. There's no truth to this. That there is a microchip or any other kind of tracking technology that's part of this vaccine, but I have heard that that's a rumor that's getting some traction.
Thank you, Commissioner. The controversy around vaccines is not peculiar to the COVID-19 vaccine. We know here in the state of Connecticut, the controversy about the safety, understanding the safety and access to vaccine beneficial and not detrimental is a conversation that many in the state of Connecticut have been engaging in an ongoing way, but it really does underscore the importance of the right information, the importance of communication, the importance of constantly seeking truth and accuracy through science. It is true that that choice is a matter of human dignity, but informed choice is what really imbues that dignity into the choices that we make. So thank you for bringing that up. James, as we start to wrap up on the hour, I wanted to come back to you because so much of the work that we're doing here is a microcosm and emblematic of the bigger work that we need to be doing in equity and access. So I want to come back to you as one of our leaders in our state who is leading these efforts on your thoughts on equity and access and the role of Access Health Connecticut. If you could just unmute.
Thank you. Thank you, Steve. Access Health, I've been sharing with Commissioner Gifford that we have developed this very unique skill set, expertise, if you will, and reaching hard to reach communities. These we used to call them the Invincibles. Those were the 18 to 30-year-olds who think that they're invincible, and a lot of them, the communication patterns are different than most Americans. very unique. So we have had to develop very targeted outreach efforts to get to this population, to get them to take action on their own behalf. Again, we are not criticizing anyone. We are not judging anyone. Ultimately, our goal is to get them the help that they need when they need it. Unfortunately, health insurance is one of those. The health insurance and health care. People typically they think about it when they need it, not before they need it. Right. So we're trying to change behaviors. Again, most of us on this call, our kids are going to grow up in a home where they're going to have access. They're going to learn that you have to take preventive care. But the population we're talking about, they have not had that exposure, so they don't know that it's normal to see a doctor on a regular basis. All right, so we have generation of behaviors that we had to work against to get them to understand how critical it is for you to take action for your own behalf. So having gone through those about 8 years of continuous efforts to get people to take action on their own behalf, communicating with them where they are, in the language that they're talking every day, the nuance within their own cultures. So those are the skill sets that we have developed. We have a wealth of data at a very detailed level that we could leverage to design specific outreach efforts for this population. I think this is where Access Health could be very helpful in getting the word out, and more importantly, getting people to take action on their own behalf. And we've done that for 8 years successfully. This is why Access Health is one of the most, if not the most successful exchange in the country, because of our outreach effort to get people to move and buy insurance and take advantage of the preventive cares. And again, we look at not just people who buy health insurance, but Medicaid recipients as well. The Access Health is the place where you go to get help for all health insurance, including Medicaid. So right now we have close to 1 million people in our database between Medicaid and health insurance purchases that we can leverage our database and our expertise in outreach effort, very targeted outreach to get people, get to those communities, talk to the communities. We've gone to barbershops on Friday afternoons. This is where most Black men go. Every Friday afternoon, they go between 5 and 8, they're getting their haircut. And this is a tradition. Every Friday afternoon, between 5 on the way home, they go get a haircut. So we've gone to barbershops across the state of Connecticut with posters and people, our employees, our vendors, in this barbershop talking to the folks while they're getting their haircut. But to do that, we have to meet with the barbershop owner, find out who their customers are. Are they Caribbean? Are they African American? Are they Latino? If they are they from Central America, from Puerto Rico, from South America? So we could place the right people in those barbershops, so they could have a connection of trust. So that when you're talking with somebody who looks like you, who speaks your language, and who understands your culture, the trust is almost automatic. I can share with you, I used to be a college football player, and I cracked my jaw. And I was scared, and I had to get an operation. They have to cut me over. This is when I was 21. This is in Brooklyn, New York. And I had never had an operation before. I was petrified. I didn't know what to do. So they took me from a room, they rolled me into the operating room. And the doctor who was administering the anesthesia to me, he's from Haiti. So he knew I was from Haiti because he saw my name, he saw my history. When he started talking Creole with me, almost all my fears went away. He started giving me instructions in Creole, our native language. All my fears went. So I know the value of connecting with people who are like you as close as possible. So at Access Health, we try to match our employees with the communities that we're serving. And again, we try to time our outreach where people are, where the communities are. Again, Friday afternoons, that's where most Black men go get the haircut. And that was one of our hard to reach targets. So we're going to Black barbershops on Friday afternoons, Saturday mornings. And if you have ever been to a Black barbershop on a Friday afternoon or Saturday morning, it's again what's called the Black Men's Country Club. this is where you go and you hear all the stories of all the news of the community, who's this, who's that. But that's where you have to go and connect with the community and get them the information that they need to take action on their behalf. And partner with the barbershop owner who has a trust with their members, their support really connects you with the community. And if you are talking to somebody who is from Guatemala and Danbury, so we would get somebody from Central America to go there and talk with. There's connection that they have that somebody in Puerto Rico would not have with that person. So again, those are the expertise and the specific detail about community, ethnicities, and nuances that we have accumulated in our database that we can leverage to get people in the right place, communicate with them, connect with them, to get them to take action on their own behalf. And at the end of the day, we got to get people to get this vaccine in their arms.
Thank you, James. Dr. Harris, along those lines of concordance, I'd like to offer you some parting thoughts as well.
Yeah, interesting. I couldn't help but think I taught effective speaking, public speaking at Manchester Community College for about 10 years. And one of the things that, the day one lesson is that it's about the audience. It's not about the speaker. It's about the effective communication, and it's about who's on the receiving end of whatever you're saying. And so as James was speaking, I'm very impressed by the way in which they're focusing on the receiving entity, not the amount of communication, but how it's nuanced, how it's tailored to who's on the receiving end. And so even as we're talking about the vaccine and Commissioner Gifford, I wanted to make sure that that's embedded in whatever you're creating, and that we channel experts in communicating effectively to the myriad of audiences, and what might work for my father George Harris, who's 87, will not work for my son Grant Harris, who's 15. And that message, if it's the same one, might and most likely might not work or be effective for those two very disparate audiences. And so I'm very hopeful that what James just mentioned is key and integral in the communication strategy, and that ties to the equity conversation that we've had too, about making sure that there's investments made in ensuring that these messages are nuanced and tailored to the communities for whom they're desired. And I think, Stephen, you started with nothing for us without us, right? And who better to go to talk to the 22-year-old? I might not be as effective as James sending somebody else to speak with that audience, right? And so I'm very excited about the prospect of these nuanced messages. I think that will be key in the effectiveness of the rollout going forward. And I'll tie that into tonight's overall conversation and recognition that the Connecticut's African American community, how diverse and the diaspora is also, right? And I mentioned, and I started by saying my mother is from Nevis and my father is from Opelika, Alabama, two very different and distinct cultures that we need to make sure that the level of sophistication and how we're communicating to those audiences is embedded in whatever we roll out for the state. So I'm very optimistic. I've been very pleased by what we've had to share. I have I am born and raised in Connecticut. I've raised my family here. I've been educated in our public schools and public colleges and universities, and I'm excited about what I'm hearing tonight as it relates to ensuring that that the members of our community are taken care of and have what they need without the disparities and access and things like that to be safe and healthy, with regard to post-COVID. So I did want to share that.
Thank you, Dr. Harris. Very thoughtful. Dr. Fortt, any parting words for our audience and from your perspective?
Again, I will just keep reiterating that prevention is the key. And, we had those original guidelines of masks and social distancing, and those those things need to still be important parts of the plan. Also, maintaining your own personal health, is Rome wasn't built in a day, and our bodies cannot stay healthy in just one weekend workout. We have to be consistent in what we do, how we treat our bodies, our temples. And 3, this vaccine is definitely a part of the plan. When it's your turn, look at your personal issues and your personal medical history and make that decision.
Thank you, Dr. Fortt. That is sound advice that we appreciate. Dr. McKinney, in asking for your parting thoughts, I want to reference the important facts that really do capture the significance of the moment and why it is that it is so important that we focus on the Black community and the Brown community when we discuss these issues. So I'd ask you if you could reiterate some of those facts, Dr. McKinney. If you could just unmute.
Certainly, and again, I want to just thank all the panelists for their words of wisdom this evening. James didn't share this with you, but I will. I'm working with James on the health disparities work that Access Health is doing, and part of that work we are looking at some of the data that demonstrates these disparities, not just in sort of the traditional morbidities and mortality causes, but also specifically with COVID. And in that area, there's great data on COVID. And so in Connecticut, about 10.9% of the population in Connecticut is Black, but we're overrepresented in the number of cases. So the number of cases is almost 16%, and the number of deaths is almost 15%. So that's not good. We're overrepresented in those areas. And so we do have to be aware of this. This is a disease nationally. We know that Black Americans are more than 3.5 times as likely to be hospitalized as white Americans, and more than twice as likely to die if they get the disease. And so this is not something to play with. And I also just want to reiterate something that about the times that we're living in. When COVID hit in 2020, it was, it hit us with a bang. And that affected the economy. So it created an economic crisis. And after the economic crisis, we had the George Floyd situation, which was a racial crisis. And now we're going through a political crisis. I don't know what else can happen. I mean, but this has created great trauma in our community. And for the provider community out there, Black folks in Connecticut and across the country have been disproportionately affected by all 4 of those crises. And so there's a lot of healing that needs to be done. And the information that's being provided tonight is, I think, going towards that goal. So again, thank you for having me on the call.
Thank you so much, Dr. McKinney. Commissioner Gifford, thank you so much for all the work you've been doing and for all of your coordinating efforts in the department and with our government and community. Dr. Gifford, Commissioner Gifford.
Thank you. Thanks, Stephen. I want to say thank you to you and the Commission for organizing this event this evening, and to my fellow panelists for a really, I think, excellent discussion of this critically important issue. I hope that many members of the public were able to listen in, and I hope that for those that weren't able to listen live, that this will be available in some kind of a format for people to check in on and listen into, because I think the information, the insights and the wisdom and knowledge that were shared here are incredibly valuable to our efforts in getting the COVID vaccine. I think on behalf of Governor Lamont and the health department, I want to assure people that issues of equity and access continue to be at the forefront of our vaccine rollout strategy. And as I mentioned in my opening comments about our desire to listen, and learn. I think that I want to reiterate that we understand, I think the points Dr. Harris, you were making about the importance of communication and tailored messages and understanding the audience were very well received points, and we will continue to iterate, but we welcome the feedback of the community and the partnership of the African American community in making sure that we get this right. There's nothing more important. I've said many times over the last 10 months that I and most of us will never be a part of a more important public health program than the one we're involved in right now. So it's an honor and a privilege to be part of it, and also critically important that we get it right. So thank you again for hosting this event this evening.
Thank you, Commissioner. State Treasurer Wooden, in so many ways, your call to action is the reason that so many of these conversations are happening. Leadership truly does matter. So I'd love to give you an opportunity to say a few parting words.
Yeah, thank you. And I'll try to be quick here because I know we're wrapping up. But first, thank you again for hosting this really, really important conversation. You know, one of many that need to take place throughout our state. As Dr. McKinney pointed out, our community is in crisis, right? In all the metrics that matter. And I am hopeful that out of 2020, with so much pain and tragedy, that 2021 can be the beginning of kind of translating that pain into a greater sense of purpose around equity. And equity in health, equity in economics, equity in education, but that's what we can focus on. And as it relates to this, you know, our health impacts all of those areas. And I'll close by saying kind of essentially what I said at the beginning. I think what we need to do around COVID-19 and vaccination, we need to validate our very real experiences and perspective of communities of color. We need to educate, and we need to demonstrate by taking the shot and modeling the behavior that we want and that we know will lead to better conditions. And then we need to repeat that same thing. So that's my message to everyone listening. You know, of course, you know, at the end of the day, your personal health and your relationship with your physician is critical in terms of whether you meet kind of the standards. But broadly speaking, the vaccines, the two that have been FDA approved, they are safe and effective, and we cannot lag behind in terms of embracing it. And so I will close with that and just say thank you again, and thank you to all the panelists. It's been a wonderful group to spend the evening with on a really, really important topic.
Thank you, State Treasurer. I want to echo your sentiments and thank everyone who has joined in our conversation tonight and for your learned perspectives and for your empathy and care in the work that you are doing. I want to recall, Dr. Fortt, that Rome was not built in a day and trust was not earned in one conversation. And we have to continue to dig deeper, to look inside and to look toward each other for the healing that needs to happen, but also the growth that needs to continue and the focus that we need to have on equity. For the benefit of our viewers, we will be listing several links to information, some materials that you heard today on our Facebook Live feed. Facebook Live is shareable, so please do so. We will also be providing this recording to CTN for their consideration so that we can spread the word and your words as far and widely as possible. And please know that the Commission will continue to work to bring the right information, to bring scientifically proven information to the hearts, minds, and ears of our peoples so that they can make the decisions that are right for them and their future and longevity. So thank you so much for all of your assistance in building what I call institutional integrity and systematized and systemic trust. With that, I bid you good night. And for our viewers, thank you so much for joining us. Good night, everybody. Thank you.
Good night.
Right.
Good night.